Ethics Untangled is brought to you by IDEA, the Ethics Centre at the University of Leeds. To find out more about IDEA, go to ahc.leeds.ac.uk/ethics. Professor Lisa Bortolotti is a philosopher based at the University of Birmingham who's been working on a fascinating interdisciplinary project looking at what happens when young people experiencing mental health difficulties talk to clinicians about those difficulties. The project has involved closely examining hours and hours of audio and video material of these encounters, as well as talking to the young people themselves, in the hope of gaining insights which can help clinicians improve their practice. Emerging from the work has been a focus on agency and the agential stance. We'll be discussing what that means and why it's important, drawing on some examples from the project. Lisa, welcome to the podcast.
Thank you.
And we're going to talk about some work that you've been doing on the idea of agency in interactions with young mental health patients, I suppose. So we're talking about the way clinicians interact with young people who are experiencing mental health problems and how they can properly take account of the idea of agency within those interactions. And I guess ultimately avoid undermining the agency of the young people concerned. So I wondered if you could just start by giving me some background to the project. So how did it come about? How did you come to be involved in it? And what are its aims?
Yes, of course. So the project is really about youth mental health. And given the topic, there is a wide range of disciplinary backgrounds that can contribute to it, because we are looking at something that has to do with the relationship between young people who are struggling or having a mental health crisis and healthcare practitioners. So we wanted to take into account both the perspective of the clinicians, and so we do have people with clinical experience on the team, but also the lived experience of the young people. So one thing that for me, for instance, was completely new, I never worked in this way, is that some of the researchers on the project were actually young people who had experience of mental health services. And so we worked with MECPIN, was this type of facilitation for research that is conducted by lived experience advisors. And we also look at how people talk to each other. So we needed someone who was experienced in clinical communication. And we had two people in the team who were looking at conversation analysis, how we can analyze a conversation and what we can infer from the conversation about the relationship between the two parties. And of course, psychology. So we had people with experience and background in clinical psychology. But I was, the only kind of official philosopher on the team, and that was really exciting. And the thought was that we had a lot of data from a previous study made of conversations between young people and practitioners in the context of emergency services, so a very specific context. And we had both the transcripts, but also video recorded interactions. And so there was a lot that we could infer, not just from what people were telling each other, but their expression, their tone of voice, their nonverbal cues. And that was really, really interesting. So what we did was just observe these video recorded interactions and discuss them and, see what the effects of what, for instance, the practitioner was saying was on the young person, and whether the conversation seemed to flow well, whether it seemed to be successful, whether there was an exchange of information between the two parties, all of this, yeah.
That's really fascinating. And reading the paper that's come out of it, some of the most interesting elements of it are the quotations that you've taken from those videotaped, recordings of interactions that illustrate the points that you made. And we'll get into that a little bit in a moment. But I was wondering, first of all, so you were the only philosopher on the team. What was your distinctive contribution as a philosopher? What were you there to do as a philosopher?
We know from our experience, and we could tell from the data, that sometimes interactions were not successful. But I think what is interesting is why these interactions fail. Why is it that they don't deliver what is supposed to be delivered, which is support for the young person seeking help? And why is it important to know the reasons for the failure? Is because, if we know what is going wrong, then we can address it. Then we have a way of trying to fix what is not working. So I guess my role as a philosopher was to think about the best way to conceptualize what was going wrong, right? So we knew that, the person felt that they weren't being listened to, that they weren't being truly supported. But what was it in the interaction that gave them that impression? What was it that wasn't working? And how could we go about, changing it? And of course, you can take it just at the level of communication and say, okay, you could have communicated this in a different way. But why is it that, that alternative form of communication would have made a difference? And so we were discussing among ourselves, what is it that, could be that the key factor? And what the young people were saying is that they didn't feel listened to, they didn't feel understood, they didn't feel they had a role, an active role to play in the conversation. So to us, that suggested that agency was a key factor, that they felt that they were not, they didn't use the word agency themselves, but everything they were kind of suggesting in terms of what could be improved, to us suggested the idea that maybe if they had been given more agency, if their agency had been kind of respected or safeguarded, then things could have gone better. So that was the big question in the project. Is it a problem with agency? And if it is a problem with agency, can we do anything to make sure that interactions go better? And practitioners are aware that, feeling like an agent, feeling an active participant in the conversation is so important to the young person at that time.
Yeah, really interesting. So that I wasn't aware that the idea that it was to do with agency, that wasn't part of the initial setup of the project, right? That's something that emerged, did it, as you kind of listened to these recordings?
Yeah, I mean,
and so
this
on?
is the first time that I've worked at a project in this way, but almost everything happened bottom up. So we really started with something that, the young people were saying or something that emerged from the transcript, and we worked our way up to the concepts. And in some case, that was so evident. Like, for instance, because we're thinking about agency, as philosophers, the first thing you think about is autonomy and responsibility. So I was really working with this idea, okay, let's look at responsibility. And it appeared from, the work that we were doing with the young people, that responsibility was not, in the end, the right concept to focus on. And so we just moved to something else. But, there wasn't really anything that was fixed at the beginning. We had an idea that agency may be involved, and that's why we called it Agency Youth Mental Health Project. But what agency was like, or, what kind of notion of agency would have been, the best one to use in this context, it was very much up for grabs. And it's something that we negotiated together in the research team.
Great. And can you say a bit about what the notion of agency that ended up being most relevant to this work?
Absolutely. So because we wanted a starting point that was accessible to everybody, so experts from different disciplines, but also people who may not have any particular academic background or expertise, like the lived experience researchers, we started with a notion of agency that was extremely kind of straightforward, like the LA conception. If there is a LA conception of agency, I think that was it. So the idea that you are an agent when you make a difference. So you intervene in the world around you, in the social world, in the physical world, and something changes because of what you do, right? So you've got this power of making things happen. And now, if we want to kind of move on a little bit from a extremely simple conception, this idea that there are things that you are interested in and things that you want to achieve, what we would call goals. And what you do is basically there because you want to get closer to satisfying your goals or to fulfilling your goals. So there is this movement that You're doing something because, there is a goal in mind that you've got and you're getting closer to that goal. Sometimes you can achieve it, sometimes you fail to achieve it, but, you pursue your goals in this way. So that is the notion of agency that we started with.
So you're kind of getting closer to your goals, but as a result of your own actions, right? So it's the input of the person themselves into reaching those goals.
And then, of course, as part of the project, this idea was redefined a number of times until we got to, some kind of what we take to be key aspects of agency. But that was very much, as we were saying earlier, a bottom-up approach. So initially we just had this kind of extremely broad conception. And working together and looking at the data, we came up with this 5 aspects of agency that, of course, I think is still a work in progress. Is still something that, we may want to work on in the future as well.
Yeah, great. Okay. I wanted to ask also, what are the risks arising from the undermining of agency in these contexts? So if a young person's having these interactions and they are feeling that their agency is being undermined, what are the negative consequences of that?
That's a really good question. So one thing to start with is that when we are experiencing a mental health crisis, whether we are, young people feeling depressed or older people, experiencing symptoms of dementia, we are already in a situation where our sense of agency is compromised. It's compromised by the situation we are in, by the mental health crisis itself. And, the extent to which agency is compromised and the aspects of agency that are challenged may be different depending on what we are experiencing. But, the world doesn't appear the same to us when we have a mental health crisis. It's more unpredictable. We feel we are not in control, not only of external things. Sometimes we don't feel we are in control of ourselves. And if you look at all different kind of diagnostic labels, what you find in common between the experience of almost all of them, it is this feeling of helplessness. That things are out of my grasp. Things are happening to me. I'm not making them happen. So there is really this idea that in a mental health crisis, you're already in a situation where your sense of agency is weak or weakened. Now, what happens is that some people report that after encounters with healthcare professionals, that gets worse rather than better. So they're put in a situation where their sense of agency is even further undermined by the type of relationship, the type of exchange that they're having with the healthcare professionals. So if you think about the dementia case, many people at the very early stage of dementia say that when they go and talk to a practitioner, often the practitioner looks directly at the carer that doesn't even look at the person with dementia because they just assume that because they have this diagnosis, they're not able to understand or they're not able to make decisions about their care or their preferences don't count. And so there is this phenomenon of infantilizing the mental health patient. It's as if, it's just a little child who cannot understand the situation or cannot make decisions. Similarly, with young people experiencing, for instance, low mood or depression, very often what they say is not taken as, the actual experience that they're having because there is an assumption that, I don't know, maybe they are exaggerating their symptoms, they're like drama queens, they want the attention or something like that. Now, all of these assumptions are not very often explicit. It's not that the practitioner believes that the person, is totally unable to participate or believes that the person just wants attention. But there is this kind of implicit bias that we all have towards people who are experiencing a mental health crisis because we associate mental health with rationality and we think, because they're experiencing a mental health crisis, then their rational capacities may be compromised. And the more serious the mental health condition is, the more we think that they've lost their capacity to, make decisions or think clearly or lucidly about their own situation. So the way in which the practitioner behaves in the interaction may confirm to the person who is seeking help that they are not in a position where they can make a difference because, maybe they're not really listened to when they talk, or maybe when they express something that is immediately challenged by the practitioner, which makes the people feel that, they don't know what they're saying, or, and so the fact may be that the sense of agency that the person has is not only compromised by the mental health crisis that they're having, but also by the way they are interacted with in the clinic. And of course, this shouldn't be generalized because is not true of all kind of clinical interactions. And we shouldn't even think that it's just doctors who do that or nurses. I mean, I think the whole of society has this issue. We have these assumptions about mental health. We have these assumptions that, if your mental health is compromised, then you may be unable to do things that otherwise you'd be able to do, that then certain rights that we would automatically give you, we take them back. And so I think this kind of mental health stigma, as some people talk about it, is something that permeates over all of our culture, and something that we can see, for instance, in fiction, in movies, how the person with a mental health crisis is represented is very often is not a very nuanced way of representing this person. Is usually someone who is not in control, or someone who is aggressive or violent, when actually the evidence suggests that these things, of course may happen, but they're not kind of, substantially correlated with mental health issues. So that was the idea, looking at what difference the interaction was making, either positively supporting the person's sense of agency or negatively further undermining the person's sense of agency.
Great. And the one concept that you use is the concept of the agential stance. So could you say a bit about what that means?
Yeah, so we talked about the kind of super broad notion of agency that we started with. And then I said we focused on 5 aspects of agency. And again, this was a negotiation among ourselves as researchers. And we thought that if the practitioner can recognize those 5 aspects of agency in the patient, in the person who is seeking help, then things might go better in the interaction. So the agential stance is basically a stance that the practitioner adopts in order to recognize the agency of the person in front of them. And so for each aspect of agency, there is one thing that the practitioner can do. I mean, of course, it's more than one thing, but, one attitude that the practitioner can take. So take the first one. So we say, if you are an agent, you have a point of view on the world and on yourself that is valuable. Other people may disagree with how you see things, but still, you still have this point of view that needs to be acknowledged as valid, as something on the table that needs to be taken into account. Now, if that's true, no matter whether you have a diagnosis of schizophrenia or dementia or depression, then the practitioner, when you describe your own experiences, needs to listen to you because what you're saying is valuable. They might in the end say, okay, you're interpreting it right like this. I'm offering you an alternative interpretation. And that's fine. But what is not fine is an outright dismissal of the experience as a product of the illness, right? So if you say, oh, you see it that way because it's a hallucination, or it's a delusion, or it's it's a symptom of your condition, that immediately communicates that experience is not valuable, it's not telling us anything important. And that's problematic because, especially in mental health, very often the report of the patient is the only thing that the practitioner can go on and examine in order to arrive at the right diagnosis or the right treatment, right? I mean, there could be other types of evidence, but not in every kind of psychiatric diagnosis. We are at the stage where, we can just take a brain scan and discover what the person has that is wrong with them. Very often, it's self-reports that are the basic evidence that the practitioner needs to take into account. So if the self-report is discounted, there is a lot of interesting information that the practitioner is not having at their disposal to make then decisions about what to do with the patient. So yeah, the validation of the person's experiences is the first step, we think, is the most fundamental. And then we move on to other things. So, for instance, recognizing that there is a serious concern. So, if the person has sought help, is because they're concerned about aspects of their health, and that needs to be made legitimate. Because we found that, for instance, in interaction, very often practitioners were saying things like, "Oh, you seem to be okay. You don't need further support." And it may be that at the end of the conversation, that's the outcome of the interaction. But at least initially, the idea is assume that there is an issue. They've come to you because they need help. So they do have a legitimate concern. And then, start kind of exchanging information and interacting with them in order to understand what the concern is, even if you end up redefining the concern in the end.
Yeah. I suppose there's an element of that which is, it's problematic because in the situation where somebody's come to you for help and you're saying, "Oh, you seem all right," that's problematic because you're discounting a lot of information which actually might enable you to make a more accurate diagnosis. So that's one problem. But it's also, there's the problem of the effect on the person of being told, right, you may think that there's a problem, but there isn't, right? And you were wrong to come and see us. And that's going to be undermining for that person, and also make them less likely to come and see somebody in future if they have a similar experience, right?
Absolutely. So that's what we found in the study, that the people who had the worst experiences with emergency services, so people who were told, "Why are you here? You shouldn't be here. Counseling services at university should have dealt with you. There was a miscommunication or something." When they're told this type of story, then they, first of all, they feel bad about themselves. They feel, they've taken up resources, or they feel guilty about having sought help. But also they're much less likely to seek help in the future when they experience another crisis, which is potentially very harmful.
Is that a product of basically bureaucracy? Is that why that kind of thing is happening? Because it strikes me in some of the examples you were giving, it's like the clinician is, what's going on in their head is thinking, who's the proper agency to deal with this person, or, who should they have been sent to? So they're thinking in bureaucratic terms and then communicating that to the person. And the young person, right, they've just come for help. They don't need to know sort of about all these kind of bureaucratic complications.
No, that's a brilliant question. I think there are lots of things going on here. So there is a problem with mental health services being underfunded and resources being limited, so that very often in the practitioner's head, you've got this idea that, okay, there is actually very, very little I can do for this person, because I'm told I have to prioritize, very severe cases. This doesn't look to me like a severe case. I cannot offer support. What am I going to do? What am I going to say? So that problem is, I think, outside the control of the practitioner. I think it's a problem with, resources, and it's a problem that needs to be addressed, but possibly not via this kind of study. Even if the outcome of the interaction is to say, "I'm sorry, there are no resources that are available to you right now," what we're saying is that the way of communicating this to the young person can be different from "you are not in the right place." Yeah. Because "you are not in the right place" suggests that they shouldn't even, have sought help, which, is problematic for the reasons we were discussing. But, it doesn't acknowledge that they are experiencing a crisis and they need help. And very often, and this really surprised me. It wasn't something that I would have expected. When we were discussing this issue with the lived experience researchers, so the young people who had access services, many times they said, "We don't want a prescription. We don't necessarily want, to be sent to other services. Sometimes it's enough that we're listened to." And in some of the positive interactions, what we did whenever we had the chances was to actually interview the young person who had been in the interaction afterwards, to see what they felt about the interaction, and also to see them 3 months afterwards to see what their situation was. And the young people we talked to after the positive interactions, they very often said things like, it was a very caring attitude. Nobody had ever listened to me about this before. Because we also have to imagine that sometimes, people don't have support in their families or they don't have support among their friends. So, that contact may be, the only chance that they have to talk about their mental health in a way that is not judgmental, that is not like, it doesn't make them feel excluded or guilty or wrong or something. So, of course, it would be lovely to have resources, but if we don't have them, at least offer, this kind of support that suggests that, yes, you did well to come here. You did the right thing. It's my problem that I cannot offer you, something. But, you are in the right place. You did well to come and talk. Let's think, creatively together about what we can do, how your situation can change.
Great. Okay. So as you were saying before, that you identified kind of 5 aspects of interaction which can be improved in terms of the agential stance, and we've heard about 2 of them already. So you talked about validating the young person's experience first of all, so just essentially listening to them, I suppose, and kind of communicating that their point of view is valuable and important in itself. And then the second is legitimizing the young person's choice to seek help. So saying, you did the right thing by coming for help. So even if there's no support that I can offer, you did the right thing. And let's talk about how to address that. The third one that you talk about is avoiding objectification. So what do you mean by that?
So this was a difficult one to find a good name for, but this is the idea that if you are not listening to what people have to say, it's very difficult to actually identify what the problem is. Sometimes, for instance, young people report that practitioners focus on one aspect of they're not feeling well, and they ignore another aspect, whereas for them at that moment, the other aspect is the most urgent thing. Like maybe, I have delusions and I'm anxious, but they just focus on the delusion and, my anxiety is not addressed. So one thing that we were thinking about was the fact that there is a lot of controversy about diagnostic labels. Right? There is a lot of kind of critical psychiatry that says, we should eliminate diagnosis altogether because it's stigmatizing and so on. And there are really good arguments for that view. But among the young people that we talked to, that wasn't so much of an issue. Like they recognize that diagnosis can be comforting, liberating, can be a way of knowing about yourself, can be an access to resources. So they were not against diagnosis at all, but they were worried about being labeled in a particular way before they had time to talk about what their problem was. So what we called premature labeling. Yeah. So you give a diagnostic label to someone because that makes things easier, right? Which kind of resources or which kind of agency to send them to. But it's not actually, it may not be the right diagnosis because you haven't actually investigated or explored the person's experience enough to be able to know that. And in some cases, the diagnosis can be very difficult to remove once it has been, once it's in your medical records, it's there. And whenever a new doctor or a new practitioner sees you, they see you through the lens of that diagnosis, right? And it's very difficult to change the diagnosis. So we thought about objectification as one interesting way of looking at it. So the person is not seen as a person with a complex set of interests and goals and needs, but is seen as a problem to solve. And in a way, it's understandable. Like you are a doctor or a practitioner, you've got a patient, you need, the patient is there because there is a problem. You need to identify the problem. But if you focus just on the problem to solve, you might miss out a lot of other things that are going on that may be important, right? So the idea of objectification is that if I just consider you as a set of symptoms, the need of a name or like an object to study rather than maybe someone who can help me discover what's going on, then I can miss out the complex picture. I might not, for instance, know about the problems in your lives that you are having that are impacted by and that impact your mental health. So we thought about that. And the idea is that if you are an agent, you're not an object. You're never just an object. You may be an object in certain circumstances, in certain kind of transactional relationships, like a customer and a shop assistant or whatever it is. But then you're a lot more. There is a lot more to you than just the role that you have in the specific context. And so we thought about that if you are an agent, you're not just an object, you are a subject, right? And so we called it objectification. And the idea is that if the practitioner adopts the agential stance, yes, they might focus on, the problem that you're having right now, but they don't miss the bigger picture. So the very good interactions that we saw, the practitioners were exploring everything. How is your family life? How are your studies? Do you have friends? How do you feel in some circumstances? And that really helped them get all the information they needed to then provide the right form of support, a form of support that even the young person recognized as suitable for them. And that didn't, unfortunately, happen all the time. Sometimes it was a more direct approach. Okay, then you need this. So that's the next aspect of agency that we looked at.
Yeah, and I suppose that must be an element that's kind of challenging for clinicians, right? Because part of your job, as you say, is to provide a diagnosis. That's a large part of what you're there to do, and having a diagnosis is going to enable you to target resources, send people to the right agency, if there's a prescription, whatever. So is the recommendation that you kind of just hold off on diagnosing a little bit? Because the way you're describing the positive interactions, it's almost like I, as somebody who has no clinical experience, if I was to have that conversation, that's the kind of question that I hope I would ask, right? Just simple questions about, what's going on in your life, like is your family life okay, how are you doing at school, maybe those kind of questions, right? So it's actually not to even really have a diagnosis in the back of your mind until you're quite advanced in the interaction. Is that the idea? Because I guess like there must be a kind of balance between on some level you're thinking in terms of like what kind of mental health problem has this person got versus just treating them purely as a person. Yeah,
so at a very basic level, there is the idea that you need validation before you can do anything else. Because if you don't know what the person is experiencing and you don't explore those experiences to some extent, then it's very difficult for you to understand exactly how you can help them. There is also some other issues. So we had, for instance, a transcript where was a young woman who had a diagnosis prior to her visit to the emergency services, but she was really worried about something else. She was worried about eating. She wasn't eating properly anymore, and she had lost a lot of weight very rapidly, and that's what she wanted to talk about. And the practitioner kept bringing back the conversation to the previous diagnosis, which wasn't unrelated. So, of course, it makes a lot of sense for the practitioner to try and see the connections. But in the interaction with the young woman, what the practitioner basically did was suggesting that the eating problem was not a serious problem at that stage, that she could manage on her own, that she didn't need additional support and so on. So this is another effect of objectification. It's not that you don't give a diagnosis. Diagnoses are there, but you focus on, I don't know, maybe the problem that you think you can address most efficiently, as opposed to the problem that is worrying the person the most. Because we know that, unfortunately, sometimes when the person is not dramatically underweight, they are not eligible for certain type of treatment. So it's possible that in the mind of the practitioner, there is the idea, I can't do very much for you when it comes to eating disorders, let's focus on the other thing. But that's not what the person is worried about. And as a result, we later on, it was obvious that was the main problem for that person at that time. So sometimes objectification also means that, I take the problem to be a specific problem that is tractable for me and makes me feel like more in control because I know what to do about it, even it's not actually the problem that you think you have. And of course, I can understand there may be situations where the person themselves doesn't realize what the nature of the problem is that they're having, and that's perfectly fine. But this idea of enabling them at least to express it and acknowledging that that's what they're worried about, I think is really important, because then they feel, okay, I've been listened to at least, that there was nothing that could be done, but at least, they suggested that, yes, it is concerning, that there are maybe small things that I can do to improve it. So yeah, sometimes it's also like, what problem shall we tackle first, or what is it that is most important? And in these situations, it looks as if the most important thing is what has the biggest effect on the person's life.
Yes.
So in that particular context, they are the experts.
Yes.
Because they're living that life.
Yeah. Okay. Thank you. Great. Okay. And then the fourth thing that you highlighted is affirming the young person's capacity to contribute to change. So what does that mean?
Yeah, so as I was saying earlier, we started with this idea of responsibility. Now, of course, if you're an agent, you need to be responsible for your actions. And it just didn't work in this context at all, because, you can be the person who initiates action and makes choices. And yet, when you are in a mental health crisis, you might not have a responsibility or full responsibility for those actions and those behaviors. And that's why in the philosophical literature, lots of really clever people came up with frameworks to address that. So for instance, Anna Pickard talks about responsibility without blame. Daphne Brandenburg talks about the nurturing stance. So these are ways of squaring a circle, basically. So the problem is you want the person to feel able to address aspects of their mental health in the future. So you don't want to disempower them. At the same time, you don't want to empower them to the point that they feel the burden of the past behavior that has been problematic or unhelpful.
Right.
But how do you do that in a coherent philosophical way, right? Because if you have the power to do good, then you also have to have the power to do bad. Otherwise, it doesn't make sense. So we talked about this a lot, and what seemed to be clear is that the young people did not want to be burdened with too much kind of power, too much responsibility. So they didn't even want to be praised for things that they did well. So there were interactions where the practitioner was like, "Oh, you did really well," and in a way you could see that the intention was good and was empowering. But at the same time, some of our lived experience researchers said, I would feel bad about that, because then that means they expect me to do the same in the future, and it's a lot of expectation, it's a lot of responsibility. So we were thinking about a way of recognizing the agency of the person without burdening the agent with this much responsibility. And we came up with this, like what the practitioner needs to do is to be able to affirm the capacity that the person has to contribute to change. And I think contribute is absolutely key, because I think in philosophy we have a tendency of idealizing agency. So thinking that, if you're an agent, you can kind of fulfill your goals by pursuing them, and you're the one making things happen. And that's all very kind of empowering, but also very unrealistic in a psychological way, because nothing of what we do in our lives depends just on us, right? So there is an environment. There are people who support us, people who undermine us. There is just the constraints of the physical environment. Sometimes we cannot do as much as we want to, or we are expecting to do things and it doesn't happen, and so on. So I think actually this notion of affirming the capacity to contribute to change is really useful even outside the mental health context.
Yeah.
I think that, I started seeing things in this way. It's not that I made things happen, but I contributed to that thing. And there were lots of other contributions, my family, my colleagues, the weather, whatever.
Yeah.
But it is all part of the recipe that generates that particular event.
Right.
And I think this is the right balance, because you're telling people, yes, there were things that were unhelpful in the past, let's say self-harm as a coping strategy. You didn't have any other coping strategy, things were really hard for you. That's what happened. But, so the distress, was a contributor to that thing. And so because you were distressed, you acted in ways that might not have been ultimately helpful for you. But in the future, with support, you can contribute to change. So the person always makes a contribution, and then it's what around the person that can also make an additional contribution. And so looking at the situation in this way, I think it really helps. And some of the young people talked about scaffolding, like the idea is that you create a structure where you can see yourself as an agent, without thinking that you are, you have unlimited powers. It's almost as if in the responsibility literature, you can be one of two things, a puppet or a superhero.
Yeah.
Either everything depends on you or you're completely passive, And the truth is, it's never like that. It's always something in between. And so it's recognizing this. And so the aspect of agency is having this capacity to contribute to change. And the attitude of the practitioner is affirming that you do have this capacity in a way that doesn't imply blame for past actions,
Yes.
but helps you to understand that you can actually contribute to better health prospects in the future.
Yeah. And so I guess the way that avoids the problem of overburdening the person is that, when things do go wrong, there's always it's not necessarily going to be your contribution that led to the thing going wrong, right? Because if you recognize that your contribution is happening in the context of all sorts of other factors that need to be in place, then when something goes wrong, well, it could be any number of reasons why it went wrong. But in the future, you still have the capacity to contribute to things going better in the future, right?
And I think that's also part of a bigger discourse in philosophy of psychiatry about and ethics of psychiatry, about seeing certain types of behaviors, not as the problem, but as an imperfect response to a problem. So think about, in my work, I focus on delusions, right? Everybody thinks delusion is the highest form of irrationality, but delusion is a response to a problem. So there is, maybe a problem at level of experience, something that I don't understand. The delusion comes as an imperfect theory about that experience that is problematic. Self-harm. Self-harm is not a good solution to a problem. But why is it there? Because the person is not able to cope with something else, right? So it's also seeing certain types of behaviors not necessarily as just as symptoms, but as imperfect forms of coping, like drinking too much or, having negative thoughts. It's not that you want to do that, but at the time, you don't seem to have another way of releasing certain type of stress or kind of reducing the anxiety that you're feeling. So I think this way of thinking about it also, I think, fits quite well with this idea of, you made a contribution with what you had available at the time.
Yeah, that's absolutely fascinating. Okay, so let's get on to the last thing that you highlight then in the research, and that's involving the young person in the decision-making process. So yeah, how should clinicians go about doing that?
Yeah, so if we want, the list of key aspects is a little bit hierarchical, and this is at the top, right? In the sense that, the mark of an agent is that they can make decisions. Really, what we think about when we think about agency, we think about someone who is capable of making decisions. And unfortunately, in clinical interactions of different types, it's very rare for the person to be involved, at least in the mental health context, in decisions about future treatment or best means of support. Very often there is an assumption that the person doesn't have the capacity to participate in these conversations with the clinicians. And now, in our transcripts, in our videoed interactions, we saw some positive examples where the practitioner suggested a form of therapy. The young person said, "Oh, I've tried this before. It's really not for me because it makes me think about, something that's problematic in my life." And the practitioner offers an alternative means of support. So there are really good examples where there is this dialogue. And again, as the young people who were lived experienced researchers with us said, it's not that the person wants the power to make a decision about the support because they don't have the competence or the access to those means of support. They just want to have a dialogue, to express preferences, to be able to ask questions, to express concerns. especially people who have a number of mental health crises in their lives. They have experienced different types of medications, different types of support. So they already have some knowledge of how they react in those situations. And that can be very helpful for practitioners to select the best means of support. So the idea is that, for the practitioner, it's important to recognize that the person can be a partner or a collaborator in this project of finding a solution. That doesn't mean that, all the responsibility of finding the right solution should be on the shoulders of the person who has a mental health crisis. And it may be perfectly possible that, the person and the practitioner have different ideas of, about what would be the best means of support. But having the exchange, having that conversation is already very important as a sign that the practitioner respects the person as an agent, respect their agency, their capacity to think of themselves and think about ways of helping themselves. So I think, that's probably what people mostly focus on when they think about agency, the capacity to make decisions. But for us, it's something that really needs to be built up from validation onwards, because if you don't kind of listen to people's experiences or validate them, then you are not in a position, to take their contribution when it comes to making a decision about treatment.
Yeah. Okay. Great. Well, we've pretty much run out of time, but I just wanted to ask one more question before we finish, if that's okay, which is just, so you've highlighted some really important aspects of, interactions between clinicians and young people there. What would you like to see happen as a result of the findings of your research? Is it a matter of, improvements to the way people are trained, or are there more kind of systemic solutions that need to be in place? What do you think should happen?
Yeah, that's the really important question, but it's a very difficult one to answer. So I think we want to see more successful interactions between practitioners and young people. And there is a lot of good practice out there. So it's a question of really understanding what makes those interactions successful and trying to give the means to practitioners to repeat those positive experiences in their own practice. So I think at the minimal level, training in clinical communication would be extremely helpful. It would already make a huge difference, because sometimes it's the tone of voice or the way we look at people when we talk to them, or even our body language, whether we lean towards them or whether, our shoulders are not in front of them. Really small details of how we communicate with people can give a completely different vibe and impression, and make people feel more listened to, more included, more important in the conversation. So, what Rose McCabe does with our clinical communication expert is actually works on training for clinicians and kind of adding everything that we have investigated in terms of attention stance to what we already know about successful communication. So I think that would be the minimal. And then, of course, we would like to see more change at systemic levels, but that's, really difficult to tackle. So it's like just a kind of a more explicit recognition that mental health may be compromised, but that doesn't take away your rationality or your agency. And I think, we see, unfortunately, that there is this type of stigma, this type of association between poor mental health and lack of rationality or lack of agency in health resources and kind of how resources are distributed and health systems, but it's more generalized to the whole of society, I think. We really see this, and sometimes when young people talk, they talk about their families or their friends or people at school, really just assuming that the moment that they have, a mental health crisis, then there are lots of things that they cannot do anymore, or there are lots of contributions that they can't make anymore, when sometimes a little bit of adjustment would make a huge difference, would enable them to contribute. So I think that's a bigger problem. That's a cultural problem. But, changing culture is something quite difficult to do overnight. So we just need to keep working on it and kind of trying to dismantle this stigma by providing examples of, ways in which, a mental health crisis can be managed with support.
Great. Well, that is all we've got time for. So, Lisa Bortolotti, thank you very much for being on the podcast.
Yeah, thank you for having me.
Thanks for listening to Ethics Untangled, a podcast from IDEA, the Ethics Centre at the University of Leeds. IDEA brings ethics to life, blending in-depth theoretical inquiry with real-world experience to address the most complex ethical issues facing the world today. If you like the podcast, please leave us a rating and review. And to find out more about IDEA, including our Masters and PhD programmes and a wide range of consultancy services we offer, go to ahc.leeds.ac.uk/ethics.